My name is Hussein Tawbi. I'm a professor of melanoma medical oncology and investigational cancer therapeutics at MD Anderson Cancer Center, and I'm the executive director of the immuno-oncology clinical drug development program at MD Anderson. Considering the question of where does this stand compared to other IL-2 targeted therapies, I think it is really a molecule that's very smartly designed and has the potential to be the best in class. The results in the clinical setting where we have responses in patients that are PD-1 refractory is really impressive. Seeing responses in diseases that are usually not responsive to immunotherapy has particularly caught my attention. So I do think it is a candidate, if not the best in class at this time. In terms of optimal positioning of MDNA11 and the treatment landscape for melanoma, I really do think that this activity that we see both with monotherapy and with combination in the second line is really impressive. I would prefer to focus on that in the short term because this is the unmet clinical need and the faster route to registration in this disease. If we get to a place where the clinical activity is validated in the second line setting and you have FDA approval, one can consider using this in the first line setting. I am quite excited to hear about the potential use of this in an adjuvant setting. In terms of treatment combinations that I would consider prioritizing, I think checkpoint inhibitor combination makes sense. I personally think that nivolumab and relatlimab or PD-1 LAG-3 based combinations, because of their low toxicity profile or good safety profile, would make probably great candidates for combinations. With MDNA11, I'd be interested in seeing what the ipi-nivo combination would look like, of course. And at this point, that would be my primary focus. In the future, if MDNA11 does have consistent validated results in the second line setting and maybe neoadjuvant, I could imagine how it could replace IL-2 in everything we do, including cellular therapies and the way that currently IL-2 is used to support cellular therapies. I really do think the field has been waiting for a good IL-2 molecule. It's the one drug that we had from the 80s that was improving survival for melanoma. It is a validated therapeutic approach, so I think having designed an interleukin-2 molecule that looks this impressive, both from a PK, PD, this has all of the determinants to be a potential winner. Thank you.
Hello, I'm Professor Igor Puzanov. I work at Roswell Park Comprehensive Cancer Center in Buffalo, United States. And my specialty is drug development in phase 1, as well as melanoma and skin cancer treatment for patients.
So, Professor Puzanov, based on the clinical data you've seen so far with MDNA11, what do you think stands out the most compared to other IL-2 variants in development?
Yeah, so I would say that MDNA11 stands out by its unique profile of engaging the beta, the chain of the IL-2 receptor, and in enhanced fashion. It avoids alpha, and at the same time, it also binds to gamma. It's a unique profile compared to the other efforts. And the clinical data stand out by its single agent activity. And what I also like about that is the clean cytotoxic profile. Very little problems with just mild cytokine release syndrome, no issues with large skin toxicity or arthralgias. The first data coming out from these clinical trials are promising, sufficiently promising to take it forward to the next step.
Where do you see as the optimal positioning of MDNA11 in the emerging treatment landscape for solid tumors, and perhaps particularly with reference to cutaneous melanoma?
I think in melanoma these days, one is almost bound or like clever to go to refractory post-PD-1 type of patient. In the US, it's probably post-PD-1 CTLA-4, or the combinations really are the new normal in the United States for sure. It's becoming new normal around the world. But refractory space, because the activity of checkpoint inhibitors in melanoma is almost the highest. And with 50% of patients surviving more than 5 years now or 6 years, it's clear that one has to address the issue of the other 50%.
So based on the clinical data you've seen to date and what you know about IL-2 biology, what other indications would you prioritize developing MDNA11 in outside of melanoma?
Outside of melanoma, I would actually prefer a basket approach, histology agnostic. because I think there is an opportunity to actually look at the biology of the tumor. For example, with the information you can glean from neoadjuvant melanoma trial and see, for example, if patients who are refractory to PD-1, but they still have the tumor-infiltrated lymphocytes in those tumors, maybe the ones who actually would be served, not just in melanoma, but in other tumor types as well.
Do you think there's sufficient data to consider testing MDNA11 in earlier, less refractory lines of therapy?
I would start probably the old school with refractory and then move to the earlier lines.
Perfect. What other treatment combinations would you prioritize testing with MDNA11? At the moment, the combination partner is an anti-PD-1, is pembrolizumab, but potentially others.
Yeah, I think that's a correct one. I like pembrolizumab as well. I would stick to the combinations which are already in use and standard, like a combination of a PD-1 with CTLA-4, that would be nivolumab, ipilimumab, or a combination of a PD-1 with LAG-3.
Perfect. In your estimation, how clinically meaningful is MDNA11's therapeutic potential if it were to continue along the same path?
More valuable than high-dose interleukin-2, which we know actually cured people with melanoma and kidney cancer. I think that could be it, and it could probably serve the population of about 20-30% of these refractory patients, and perhaps with multiple histologies, but we don't know that yet.
I think we touched on it briefly earlier, but about this new trial that has been recently highlighted, the NeoSight trial of MDNA11 in combination with ipi/nivo in cutaneous melanoma. How excited do you think you are, obviously, and should the community be about that with MDNA11?
I am excited because the ipi/nivo is a new standard. We know that not everybody responds. The complete response is 57% or so, and then we have 20-25% patients who are non-responders. If we see some of those non-responders convert into responders, there you go. And even for responders, potentially a very unique and a valuable drug.
Perfect. Dr. Pizanov, thank you very much for your time and your insights today.
You are welcome.
Thank you.
Tony Schwery, Dana-Farber Cancer Institute, Boston.
So the first is obviously renal cell carcinoma is regarded as a tumor type that is sensitive to immunotherapy. How attractive do you think an IL-2 based superagonist is for improving efficacy and objective responses in renal cell carcinoma compared to current regimens?
An IL-2 superagonist, IL-2 is an established regimen in renal cell cancer, not used much now because of the toxicity and the low response rate, but anything that shows responses initially in the ICI refractory setting could be quite interesting in renal cell.
I believe you've seen some of the data with MDNA11. So if this were to continue to show single agent activity that were deep and durable, so clinically meaningful in the post-checkpoint blockade patient population, would you regard that as potentially meaningful to test in a renal cell carcinoma patient population, given that historical precedent of IL-2?
Absolutely. I think a 20% response rate will be extremely meaningful, especially if these responses are durable and the toxicity are manageable. To take it to the post-PD-1 setting, which remains an unmet medical need for immunotherapy. We don't have immunotherapy that are approved in the post-PD-1 setting, so that will be quite enticing, especially if they are durable.
At what point do you think we could start testing MDNA11 in earlier, so perhaps even first-line settings?
I think taking it and building on the IO or IO-VEGF is very reasonable. I love the tail of the curve, like what happened when CTLA-4 was added to PD-1, P was added to Nivo. With the IL-2, that will be a big win. We in metastatic RCC are still now curing some patients, but certainly a minority, and hopefully IL-2 will make a comeback.
My name is Paolo Ascerto. I'm a medical oncologist. I'm full professor of oncology at the University of Naples Federico II. Also director of the Department of Skin Cancer, Cancer Immunotherapy and Development Therapeutics at the National Cancer Institute of Naples, Fondazione Pascal. Immunotherapy changed the story of several diseases. Melanoma is one of these. The idea to design the NeoSight study was to add MDNA11 to the checkpoint inhibitor, ipilimumab and nivolumab. The goal is to demonstrate that the addition of MDNA11 to the checkpoint inhibitor, it's something that can increase the benefit. There is a lot of expectation for this study. It will be an Italian study with possibility to add centers outside of Italy. Looking to the MDNA11, the genetically modified IL-2, and looking to the phase 1 study, one of the important characteristics of this kind of IL-2 is that we have seen a response in some cancer, like pancreatic cancer, that in general, historically, are resistant to immunotherapy. So this is an important signal. We had also other interesting responses. And all these aspects make MDNA11 very intriguing for possible combination with the classical approach with ipilimumab and nivolumab. The major pathological response rate is about 60%. And with the addition of the MDNA11, we wanted to get at least 10% more. So 70% could be an important milestone for us. Probably one of the best place for MDNA11 could be the second line, the patients who progressed after checkpoint inhibitor. After checkpoint inhibitors and target therapy, there is nothing. And I believe that in both settings, so the neoadjuvant and the second line MDNA11 in combination can have an important role.